Ahead and get started. Looking forward to this morning's webinar. My name is Corbin Blakey. I'm the Vice President of Sales here at HealthSnap over the last few years. Looking forward to going through a bit of remote patient monitoring 101, how to manage chronic conditions and diversify revenue streams. Looking forward to speaking a little bit about chronic condition management as well as we go through our webinar this morning. A little bit of background on HealthSnap before we get started, as I know there's a lot of new vendors that are joining the space as of recently. We actually were founded in 2015 out of the University of Miami's Lifestyle Health Department. So more so beginning as a lifestyle data analytics platform, connecting patients to devices, making sense of that data and providing personalized insights back to our users. So I know there's a lot of different companies that might be device kind of focused to begin with as a company, and then kind of adding on from a software perspective, but HealthSnap differentiates ourselves kind of running into the CPT codes rather than building our business around them. So as we go into RPM today, kind of the session overview, we're going to go into kind of what does it mean? What are the CPT codes specific to the program? How RPM supports optimal chronic condition management, and then some real life workflows on how to successfully deploy a RPM program. So ordering RPM, getting our patients enrolled, connected to a device, monitoring data transmission, documenting the time spent reviewing that data and or interacting with our patients, and then triaging that information to the appropriate care team members. So typically I like my meetings to be as collaborative as possible, but obviously that's a bit difficult with a webinar, but please feel free. We do have a Q&A that is available. We will go over those at the conclusion of our meeting. So please don't hesitate to ask any and all questions. Thanks so much. So let's give a little bit of background of kind of the purpose specific to a virtual care management platform like HealthSnap. So more often than not, we're seeing the existing care delivery methods being a bit more reactive, episodic, and then more often than not delivered in the clinic. So we're seeing these gaps in cares in between doctor visits that may result in a critical health event. So with HealthSnap, we're working to become more proactive and continuous and meeting our patients where they're at, which is more often than not inside their home. So collecting that data, using that data to support the appropriate clinical support at the appropriate time, no matter where that patient may be. So let's get into the codes themselves, a bit of a baseline of the program. So we begin with CPT code 99453. That is a one-time code, the initial setup and patient education on the use of the equipment itself. I'm going to read out a bit of the Medicare national reimbursement averages as we go through this code. Specific to 99453, it's $18.48. We work into our monthly codes. We have CPT code 99454. That's 16 days of remote data transmission in a rolling 30-day period. That data needs to be collected passively, meaning that data cannot be manually added. The average Medicare national reimbursement specific to that code is $55.77. Then we have our time spent code, CPT code 99457, the initial 20 minutes spent reviewing data and or patient interaction. And then 99458 is each additional 20 minutes spent reviewing that data and or interacting with our patients. So let's say in a calendar month, we have a total of 60 minutes spent with a patient reviewing data and or interacting specific to that data with that patient. We would be billing one unit of 99457, which the Medicare national average reimbursement is $50.18, and then 2 units of 99458. And the Medicare national reimbursement average for that code is $40.84. And then real quickly, I wanted to talk to the CCM codes that are not listed on the screen. There was quite an uptick in reimbursement in 2022. So we've seen a large increase in interest specific to that program. You have 2 codes for CCM, 99490. That is, again, the first 20 minutes spent interacting with that patient specific to their enrollment in the program. Medicare national average reimbursement is $64.02. And then 99439 the add-on code specific to CCM, which reimburses a Medicare national average of $48.45. So we go into most of our RPM vendors, CCM vendors, our virtual care management solutions. They tend to have three major areas that would be of the utmost importance during your evaluation to sort through. We see some of our usual use cases here at the top of the screen: hypertension, heart failure, obesity, type 2 diabetes. Point being that typically a patient's enrollment in RPM or CCM is typically diagnosis driven, specific to the chronic condition. But we look at an offering, we look at the solution, typically it breaks down into three major areas, beginning with the software itself. So beginning with the virtual care platform, HealthSnap, we have a browser-enabled platform. We also have a smartphone application that's accessible by both our providers and our patients. But it's not absolutely necessary in terms of a patient's need to have a smartphone, download an application to participate. As you scale out an RPM program, definitely a point of consideration is integration capabilities. We're going to talk about that a little bit later in our presentation, but really sort through kind of who does what in what solution. We have pre-configured cellular enabled devices. So devices is obviously a big piece specific to the RPM program. So connectivity is a huge point of emphasis within your evaluation. So with HealthSnap, we have our cellular devices being cellular enabled themselves. Again, so a patient does not need to have a smartphone. They do not need to download a smartphone application. They do not need to pair that device to any sort of software. So we want to make that enrollment extremely easy, specific with RPM and CCM. Typically, we're working with our Medicare beneficiaries. So if that onboarding process is difficult or uncomfortable for our patients, there might be a bit of resistance to react or engage with the device, which ultimately we're going to see our compliance percentages lower from there. On our screen, we're going to see a cellular enabled weight scale, cellular enabled blood pressure monitor, glucometer, and pulse oximeter. We can speak to kind of our additional devices available as well. And then from a care management perspective, companies might provide non-clinical resources, clinical resources. Here at HealthSnap, we provide both, but it's up to the client on which program they would be moving forward with. From a non-clinical perspective, and we'll get into workflow here shortly, being able to provide onboarding services remotely. What exactly does that look like? And then do your non-clinical care management. Are they managing patients' compliance as well, specific to their use of the equipment? And then from a clinical perspective, kind of what is the licensure in terms of the clinical support of the individual that's going to be working with your practice? And then definitely defining a workflow specific to that integration of that clinical staff. What does that look like? Is that completely segmented from your group, from your health system, or what does that interaction with your staff look like? So when we go into our workflow, again, we're going to break down into three major areas, beginning with patient identification. This is a nice simple graphic here, but we understand there's multiple layers to this process. Again, with patient identification specific to RPM, the qualifying criteria is going to be based on medical necessity deemed by the ordering provider. With chronic care management, it's a bit different with the qualifying criteria, as we're going to be working specifically with Medicare beneficiaries with at least 2 chronic conditions expected to last at least 12 months through the extent of their lifetime. So having a firm idea and direction specific to that process of the potential patients of your panel that would be appropriate for the program, something that you would like to define in implementation. And then once we have that patient identification process determined, how are we going to outreach to these patients? So a lot of groups really rely on the provider at the point of care to identify a patient, introduce the program, and enroll them, which is a great workflow, and definitely taking advantage of that provider and patient relationship to gather that patient's enrollment and get them enrolled in the program. But when we're looking to scale to thousands of patients enrolled within a practice in a health system, that's a heavy lift if we're relying solely on point of care enrollment. So working through a strategy that makes sense and that you're comfortable with as an organization, working with your vendor, whether or not there's direct mail campaigns, automated phone calls from your providers, direct phone calls from your vendor of choice. Are we going to be white labeling that communication? All things to consider in your evaluation. Depending on that patient outreach strategy, you should develop a patient consent process for when that patient opts in, whether that's written, so within the office, or if we're sending a document directly to that patient to acknowledge, or if we're collecting that consent verbally. We want to make sure that that consent process is properly documented, whether in your vendor of choice platform or in the EMR directly. And then a big piece of patient consent and patient opt-in is setting proper expectations in the program. So just a quick example specific to RPM, that it's not inherently 24/7 monitoring. So if a patient were to take an abnormally high reading in the middle of the night, we just want to set the appropriate expectation for care team follow-up. Differing CCM is 24/7 monitoring. So having, clinical staff available all day, each day of the week is something that you would need to have available to your patients. Then you have a mechanism of how the enrollment is sent to your vendor of choice, whether that is an order, referral out of the EMR directly to the vendor, or you're using the vendor software platform to enter that patient, whether in RPM, CCM, or both programs. So once that enrollment is received, it's how do we get that patient connected to our device specific to the program that they're enrolled in. So whether or not we are drop shipping a piece of equipment that's pre-configured directly to that patient, walking that patient through taking the device out of the box, throwing in the 4 AA batteries, turning that device on, taking a test reading, confirming that that data is being collected appropriately, is definitely recommended. We want to build, again, trust and credibility in the program that this data is being received and that someone is actively monitoring that data. Or having groups have a small number of devices on site, again, taking advantage of that point of care enrollment. Patient has opted in. Let's not have a time lag in terms of a shipment of a device to a patient, taking advantage of that unique period of time of having the care team, piece of equipment, patient all in one area. So working with your vendor to train on how to connect that patient to that device personally by the partner organization. So connecting that patient to the device, the initial setup and education on the use of the equipment would fulfill CMS requirement for CPT code 99453, which again is a one-time code. As we move forward into our monthly codes, we have CPT code 99454 again, 16 days of remote data transmission in a rolling 30-day period. So what to really evaluate when you're speaking to vendors here is there anyone monitoring that patient's compliance specific to their use of the equipment? And what is the verbiage that they're using in terms of that patient outreach and how they're reaching out to those patients? Quote unquote bothering, as I've heard from some partners, their patients to use their blood pressure, but we're not actively providing clinical support off that data, could definitely sway a patient from not being as compliant on the program. So the idea being is, it's so important to take your blood pressure, Corbin, so we can provide the appropriate clinical support. So if there were to be a reading out of range, that, we can take the proper care of you. And then from a software perspective is how we're tracking that data. How is that data being received by our software? Are we able to show that data in a more actionable format? Are we able to have the proper documentation specific to the billing of the code? So all things to consider when you're evaluating vendors. And then finally, we have our communication and reimbursement piece. So specific, again, CPT code 99457 is the initial 20 minutes spent reviewing data and or patient interaction. 99458 would be each additional 20 minutes spent reviewing that data and or interacting with that patient. So kind of what does that process look like? I would always recommend using references in your evaluations, speaking with groups that have a projected volume of patients that you're looking to bring onto the platform, and how does that clinical staff communicate with your patients? Is that being done by the vendor? Is that being done in-house? Is that strictly via real-time vital sign monitoring? Do we have monthly patient consultations outside of that triage of information that's being scheduled specific to the patient's enrollment? So what exactly does that look like? Sample provider notes, all recommendations when looking at vendors. And then at the end of each month, obviously there's a financial portion of this program. What exactly does that look like? What does our process look like there? With HealthSnap, we generate an RPM billing report that is patent approved, that shows very clearly which patients have met the eligibility requirements for these CPT codes, whether RPM, CCM, and then depending on whether or not we have an active integration, we would be able to automatically enter those charges and submit those claims following provider review, as well as the ability to manually enter those charges, submit those claims. And with our partners, 2 thumbs up, we're seeing average days of reimbursement 16 to 22 days with a first pass clean claim rate of 98 to 99%. So the idea being is we're getting paid quickly and we're getting reimbursed on that first claim submission. Just one thing to think through with a billing perspective, we have customer success managers, big focus, really 2 major areas is going to be around patient clinical outcomes and then reimbursement. So how much visibility does the partner have in that process? Is that data readily available? Do we have to ask our groups to pull that data on behalf of our own patients? And then really just having the visibility from a billing perspective. Typically our groups are billing, well, our groups with HealthSnap are billing personally, but I've heard, other groups do things a little bit differently. So just when people are acting as an extension of your group, you just want to have a lot of visibility in that process, as ultimately it will come back to the practice. So again, we spoke to some use cases, but I just wanted to reiterate kind of the feedback that we've received from our patients specific to the program. Some specific use cases that we see with our internal medicine partners. So pre-hypertension, uncontrolled hypertension, weight management, obesity, prediabetes, type 2 diabetes with chronic kidney disease. But we've had a lot of positive responses from our patients enrolled outside of the clinical outcomes themselves. But we had 100%, yes, 100%, crazy statistic, report a better sense of security specific to their chronic condition, knowing that there is a care team monitoring them in real time. 84% much more sense of control specific to their health, 16% some more. 100% much more understanding, a greater sense of understanding specific to their health. And then 75% reported large changes upcoming specific to their lifestyle, 25% some changes. And that takes us back to HealthSnap's roots specific to lifestyle health. A lot of the clinical support that we provide is going to be lifestyle based. So exercise, nutrition specific to that patient's chronic condition. We've seen that as a unique differentiation in terms of patient compliance. Connecting a patient to a device, not necessarily the most novel portion of the program, but how do we keep that patient compliant to the program based on the value or perceived value that they're receiving from the program? And that's really how we make these programs work. We're going to talk about integration here moving forward. Sorry, quick time check. Just want to make sure that we have time for questions. I like to call this our not so standard EHR interface overview. So one thing to consider is whether or not a group is doing their integrations in-house or they're outsourcing with a company. We use Redox, absolute rock stars in the space. We're not trying to be, an integration company. We understand kind of where we fit in this puzzle. We have best of breed partners, and that's what we're going to rely on in some aspects of our offering. But what this integration typically looks like, single sign-on, so the ability to open a patient's profile within HealthSnap directly from the EMR practice management solution, inbound flow sheets, so the ability to push discrete data directly back into the patient's chart, so the actual blood pressure meetings, weight readings, outbound flow sheets. So the ability from user submitting, an encounter note documentation within the EMR, pushing that to HealthSnap, making sense of that data so we can appropriately bill at the end of the month. And then finally, our inbound financial. So again, we spoke to that briefly earlier on, but the ability to automatically enter those charges, submit those claims following provider review, and then with the inbound media, having all the supporting documentation to bill out for those codes. So in summation, some of our key takeaways that RPM is the easiest way to shift from reactive episodic care to proactive ongoing care for effective chronic condition management. Even more so with the addition of CCM, those monthly patient consultation, we've seen the combination of those two programs work out really, really well. RPM is a fairly net new billable book of business that allows you to extend your practice reach and diversify your revenue. So a lot of our partners have not billed out for these CPT codes before. So a big piece of what we do is work very hands-on on that billing cycle for the first several billing cycles, just to make sure that we have the appropriate dates of service when we're submitting these claims. And then RPM, like CCM, requires the right partnership for your organization that can handle secure data transmissions, clinical compliance support, and easy to use hardware. So again, there's a lot of aspects when you're evaluating an RPM vendor. So I'm happy to, discuss offline what exactly that might look like and what to really focus on during your evaluation. So I want to check our Q&A. I appreciate y'all's taking time out of your busy day to walk through the platform, or excuse me, the presentation today. It's much appreciated. Looks like we have a couple questions. Let me just take a quick water break. So first question, what is the average implementation timeline and what does that look like? It's a great question. So with our implementation, what we see on average with our clients obviously depends on if it's a private physician group with 1 or 2 doctors or an enterprise health system with 8,000 physicians. But that implementation timeline typically is 4 to 6 weeks. How that looks like is we have a customer readiness form. So we're going to collect a good bit of data up front specific to your organization and your perceived workflow. Takes about 10 minutes to complete. From there, we're going to have our kickoff implementation. So we're going to walk through the feedback that you've provided within that form and collect any determining factors specific to the workflow. And then from there, we'll have our training and then we're ready to onboard patients. So you would be introduced to your implementation manager and your customer success manager who would walk you through that process. What is the most important things to consider when it comes to engaging patients in an RPM program? That's another great question. I like to think of, again, we're working with our Medicare Advantage patients. I like to think of my grandfather in Washington, Illinois, remote area. How would this make most sense when we're, introducing the program to him? Patient needs to be, tech adverse. He has a flip phone. So how do we appropriately engage that patient, making it super seamless to enroll a patient? So I very much recommend cellular enabled devices without a smart hub. Smart hubs can be, a bit distracting or confusing in themselves. So that's just something to consider, making it extremely easy, setting proper expectations, and then obviously fulfilling on those expectations. Okay. So we have a couple of questions around devices. We provide a glucometer, so it is a finger stick. We are working with the big vendors, as I'm sure you're all aware of, specific to CGM. So we are working through that process. So really excited about that. Specific to what's coming up, we're in discussions around COPD use case, so the use of an inhaler specific to respiratory. We also have had a lot of interest specific to remote therapeutic monitoring. So that's something, more so around pain tolerance, more survey-based specific use cases there. So those are a couple potential. And I will be providing my email address. Again, we're kind of coming up on time. So if there's any additional questions that I do not get to, I want to make sure that I'm able to moving forward. Happy to discuss the costs on more of a one-on-one. We do have a number of different programs available. So what we spoke to, we have what we call our remote package. So that is dependent on providing software, devices, and then our non-clinical support. Specific to our Remote Plus package, we provide software, devices, and then non-clinical plus clinical services. So RNs, LPNs, specific to monitoring that program in real time. Does a patient need an RX to onboard a patient? Sorry, just Andy, reading your question here. Patient need a prescription. So we typically have that enrollment form. Really that qualifying criteria specific to the patient's enrollment is diagnoses driven. So to your point, it can be prescriptive in manner, but really that enrollment form that's showing, Corbin, based on your uncontrolled hypertension, we're enrolling you in our, remote patient monitoring program. What this looks like, we're going to deploy a cellular enabled device, blood pressure monitor to you, and then provide any clinical care instructions. And then again, provide the expectations specific to the program. So specific to, justifying that patient's enrollment in the program, again, that's deemed by the ordering provider specific to medical necessity. Typically, we focus on Medicare Advantage patients just with the lack of patient responsibility dollar if a patient has met that deductible. These are simple E&M codes, so it's going to be similar to that to an office visit if a patient hasn't met that deductible. What we're seeing with other commercial payers, it's recognized more often than not, reimbursed, but that's going to be specific to your contract with that payer. I think we are coming up on time. We have one more minute. So if we have one more question, happy to help. If not, my email address is on the screen, Corbin, CORBIN @healthsnap.io. And I'm happy to schedule, subsequent time to walk through the HealthSnap platform itself and show off our software a little bit. I appreciate all y'all's time today. Hope you have a wonderful rest of your day. Thanks so much. Bye-bye.